The CT thorax represents what? So in this image, no history has been given. It's a direct spotter which has been asked. So here we see that the ascending aorta is number one dilated, yes, and we see this intimal flap. This is known as an intimal flap, which is dividing this aorta into two lumens. This is one lumen and then this is the second lumen. So what is the diagnosis? This is aortic dissection. This is aortic dissection, and since the anterior aorta or the ascending aorta is involved, this will be an ascending aortic dissection. Now, in an aortic dissection, it's very important for us to identify the true lumen and the false lumen, because the intervention depends upon wherein you put in the stent. So if you put in the stent in the true lumen, the false lumen will disappear and the dissection will be treated. However, if you put in the stent wrongly in the false lumen, you are inadvertently closing that artery. Hence, it is catastrophic. So remember, true lumen will always have a higher contrast, very bright contrast, because the contrast is in the true lumen. So this will be your true lumen. The area of the aorta which has less contrast, less bright appearing contrast, this will be your false lumen. Never go by the size of the lumen. So false lumen can be large because continuous blood is flowing through it and no blood is coming out of it. So the blood keeps on accumulating and it enlarges in size. So never go by the size. See the contrast density in both the lumens. Now, since we are on the topic of aortic dissection, we'll quickly discuss the classification system. So Stanford divides aortic dissections into type A and type B. Simple. A is ascending aorta involvement. So whenever you see ascending aorta involvement, it is always and always Stanford type A. Now, further, these have been divided by DeBakey into 1, 2 and 3. Now, if type A has everything involvement, everyone involvement, A है तो ascending aorta होगी, but arch, descending thoracic, abdominal, everything is involved. This is DeBakey type 1. ठीक है, so 1 is everyone is involved. Now 2 is only ascending aorta is involved. Now coming to Stanford type B. So type B will divide into A and B. DeBakey A and B. So A is above diaphragm. That is only the part of aorta which is above the diaphragm is involved. That is will be DeBakey type 3A. And if both above and below are involved, this is DeBakey type 3B. So this was about your aortic dissection. Now let's move on to the next question. An elderly male presented with multiple bone pains, anemia, renal failure, proteinuria and hypercalcemia. So what are the buzzwords? First of all, it's an elderly male bone pain. So it's a bony pathology we are talking, but it has some systemic features. So what are these features? These are the crab features that we read in multiple myeloma, correct? And what do you see on the skull X-ray? You see these multiple lytic lesions throughout the skull, correct? So what will the diagnosis? So these multiple lesions can either be METs, multiple myeloma, hyperparathyroidism, but then you have to rely on the history also. So since this patient has anemia, renal failure, proteinuria, bone pains, and it's an elderly male, the most likely will go with the answer of multiple myeloma. So right there at the outset, we quickly see all other important skull X-rays as well. So in hyperparathyroidism, okay, if the scenario of hyperparathyroidism is given, what kind of question will it be? So patient will have renal colic because there are stones which form in the urinary system. Patient will have bone pains because of the lytic lesions in the bone. He groans and moans because of hypercalcemia, which affects the CNS. So these are typical features which are described for hyperparathyroidism. And what is the appearance of skull that is seen in hyperparathyroidism? We call it salt and pepper skull, also known as pepper pot skull. salt and pepper skull or pepper pot skull. Now, some other appearances of skull not related to hyperparathyroidism but comes as a spotter. So this crew cut appearance or hair on end appearance, so we call it hair on end or a crew cut appearance. This is seen in thalassemia. Okay, thalassemia, or in general you can call it hemolytic anemias. Hemolytic anemias. So hemolytic anemias will also include hereditary spherocytosis, hereditary leptocytosis, thalassemia, etc. Now, if you see on skulls, big punched out lesions. So the buzzword being a punched out lesion with beveled margins. Then the answer will be eosinophilic granuloma. Eosinophilic granuloma. But in a skull x-ray, if you are seeing multiple lytic lesions with bone pain, with crab features like renal disease, anemia, proteinuria, etc., benzoin proteinuria, and plasma cell infiltrate on bone marrow aspiration or biopsy, then you know that you are dealing with multiple myeloma. Correct? And similarly, just last spotter of skull, and that is related to Paget's disease. Now, Paget's disease we know has a lytic phase and a sclerotic phase and a mixed phase. So, in lytic phase of Paget's disease, we get this well-defined large lytic area in the skull. This is known as osteoporosis circumscripta crani. So this is seen in lytic phase of Paget's disease. And in mixed phase, we'll see this some areas of sclerosis, some areas of lysis within the skull. This is the cotton wool skull. This is the cotton wool skull. And it is seen in which phase of Paget's? The mixed phase. So this was about your various appearances of skull. Now, moving on to the next question. A 40-year-old male was brought to the emergency with severe abdominal pain. On examination, the pulse was 112 per minute and the systolic BP is 80 mmHg. So we know that it is hypotensive. The patient has tachycardia. So the patient has hemodynamic instability. Okay, patient has hemodynamic instability and a chest X-ray is given below. So what do we see on a chest X-ray? We see that there is air beneath the diaphragm, this crescent shaped air in the diaphragm or pneumoperitoneum, and this tells us that there is some perforation. Now, whenever there is a perforation and the patient is hypotensive, first is resuscitation, that is you will give IV fluids, you will try to maintain the BP, give inotropes if necessary, but eventually the patient has to be taken into OT because the patient is going into sepsis. You have to stop the perforation. So the answer here will be exploratory laparotomy. The next step in management, appropriate step in management amongst the given options is an exploratory laparotomy. Now, since we're on the topic of pneumoperitoneum, let's read the various signs of pneumoperitoneum as well. So first is your Wriggler's sign. So what does Wriggler's sign say? Is that whenever there is extraluminal air, the bowel wall will be very well visualized because air is both outside and inside the bowel. So the bowel wall is very well visualized. This is your Wriggler's sign. Now some signs of massive pneumoperitoneum, very large air in the abdomen. So one of them is a football sign. Okay, the abdomen is in the shape of football. This is mainly seen in infants because they have small abdominal cavity. Now, if your air is beneath the central tendon of the diaphragm, this is known as the cupola sign. Okay. Similarly, in cases of massive pneumoperitoneum, the ligaments within the abdomen get outlined. So if your falciform ligament is getting outlined, it is known as the falciform ligament sign. And similarly, if your lateral umbilical ligaments are getting outlined, this is your inverted V sign. Now, another type of sign which is seen in small pneumoperitoneums is this triangular air which gets entrapped within the bowel loops. So, this is the telltale sign or the triangle sign of pneumoperitoneum. And if your air is in the Morrison's pouch, this is the Doji cap sign of pneumoperitoneum. Okay, let's move on to the next question. A 30-year-old patient presents to the casualty with after motor vehicle accident. He has bruises on his chest. His pulse is 100 beats per minute. BP is 125 by 85. That is, the BP is maintained. Respiratory rate is slightly tachypneic, 28. A chest X-ray was performed and is shown below. So what do we see on the chest X-ray and what is the most appropriate next step? Now here we see that there is this hypolucency, radiolucency involving the right hemithorax. So this tells you there are no bronchovascular markings. So this is not a normal lung. And this tells you that there is this massive right pneumothorax. We can also see the tracheal shift to the opposite side. Now, so we are dealing with a large pneumothorax. So what should you do? Should you put in a needle thoracostomy or should you put in an ICD? So it depends on the patient's clinical status. Since in the question, it is given that the patient is hemodynamically stable. So we have time to put in an intercostal drainage tube. So here we'll do a chest tube placement and drainage. But if it was an unstable patient, let's say BP was 85 by 50, patient is crashing, going into hypotension and shock. Now we want to immediately decompress the chest. We don't have time to put in an ICD. So we'll do in that case an emergency thoracotomy. I hope this is clear. So let's just quickly revise the various pleural pathologies. So one we have already read. It is pneumothorax. How do you identify pneumothorax? You see this visceral pleural line which is compressing onto the lungs, and outside this visceral pleural lines we do not see any vessels. This tells you that there is free air within the pleural cavity and we call it pneumothorax. Now treatment of pneumothorax, as we have already told, if stable patient will put in an ICD. If it's an unstable patient, we'll put in a needle thoracostomy. Now the second image, what do we see here? We see that the right CP angle is blunted. We see blunting of the right CP angle. So this tells us that this is a pleural effusion. And what is this sign that we are seeing here? This is the meniscus sign. But if you see air fluid level, you see a proper level within the pleural cavity, and outside this air fluid level we have free air. That is, we are not seeing any bronchovascular markings. So this is free air and there's a level. So that means that there is an associated fluid component as well. So this is a hydropneumothorax. So this is a hydropneumothorax and this also needs to be drained. So we'll put in an ICD, intercostal drainage tube. Now the next question, we've already read this. What does the following X-ray depicts? We know that the right CP angle is blunted and showing a meniscus sign. So this is a pleural effusion. Simple for us. Since we're the topic of chest X-ray, and chest X-rays are very commonly asked in your exams. So let's firstly label the various bones. How do we count ribs? Okay. So first of all, whenever you're counting ribs, remember you have to go from anterior to posterior. Okay, this is the rule. So how will we count the ribs? This will be our first rib. This will be our first rib. Likewise, this will be our second rib. So we are going from anterior to posterior. This will be your third rib. So we have labeled this as well. This is the first rib, the second rib, the third rib, and we are going from anterior all the way till the posterior. Anterior to posterior. This is how we count the ribs. Similarly, these are the two clavicles. This is the scapula, and in the center we have the vertebral bodies, which are very well labeled. On a lateral chest X-ray, what do we see? So we see that the anterior air containing structure is the trachea and the esophagus is posterior to the trachea. Now on a lateral chest X-ray, the most anterior structure is the right ventricle. So this is your right ventricle, and the posteriorly located structure is your left ventricle. This is your left ventricle. Correct? So this was about your lateral chest X-ray. Now aorta goes and from anterior to posterior. So this is how your aorta goes. This will be your aortic shadow, and the main pulmonary artery is shown with this yellow lines. Now on a chest X-ray, whenever you see a opaque hemithorax, what is an opaque hemithorax? That one side of the thorax has completely white out. So unilateral white out lung. We are reading the DDs of opaque hemithorax or unilateral white out lung. In such cases, we have to see the trachea. So if the trachea is ipsilateral, so we are labeling trachea here, we are writing trachea, and if the trachea is ipsilateral to the opaque hemithorax, that means that there is a pull towards that lung. So this means that there is a right lung collapse. Okay. But if the trachea is contralateral means it is pushed towards the other side. Why will it be pushed? Because there is a massive effusion or a mass which is occupying the entire left hemithorax. So this is either left pleural effusion or a large left lung mass. So for example, chest wall masses like Ewing sarcoma of the ribs can become so huge that they can occupy the entire left hemithorax or one side of hemithorax, and that is exactly how they look. So either a left pleural effusion or a large lung mass or basically a large chest mass. But if the trachea is in center, okay, so if the trachea is in center, so it is either consolidation or a pleural effusion with an associated underlying collapse of lung. So these are the DDs of opaque hemithorax. Moving on to the next question. Identify the radiological procedure shown below. So an easy question. So we see oral contrast going into the stomach. So this is the stomach. This is the duodenum. And then opacifying the rest of the small bowels. So the part just next to the duodenum, this is the jejunum, we know. And then we have this ileum. So remember, so first of all, which investigation is this? So it is BMFT or barium meal follow through. Now how do we identify jejunum? Jejunum has feathery appearance on barium meal follow through, whereas ileum is featureless. It does not have any feathery appearance. Now let's just see various barium studies and in fact various radiography and fluoroscopy images of the bowel. So first of all, we have already read this is the BMFT, right? In BMFT, what do we see? Normally the jejunum is towards the left and the ileum is towards the right. But if this relationship is not maintained, that is the jejunum is towards the right and the ileum is either in the pelvis or towards the left, That means that this is a case of malrotation. Remember, jejunum coming onto the right hand side is abnormal and signifies it being a malrotation. Such children are more prone to midgut. So such children are prone to midgut volvulus. Now, which is the next investigation? We see a tube in the rectum and there is contrast opacifying the entire large bowel. So this is a barium enema, right? And what do we see here? We see these small outpouching from the sigmoid colon wall. So this is nothing but diverticulosis. Diverticulosis. For diverticulosis, remember the investigation of choice is a barium enema. But if a diverticulitis is asked, then the investigation of choice will become a CECT. Okay. Now, which is this fourth image? So we see that the small bowel is getting opacified with barium, but we very well see the wall of the small bowel. And if you look closely, you will also see a small tube within the small intestine. So this is nothing but enteroclysis, barium enteroclysis. That if we put in a nasojejunal tube, this is a nasojejunal tube that we have put in, and after giving barium through that tube, we push in some air so that the barium gets stick to the walls of the small intestine, and we very well see the mucosal pathologies of the small bowel. This was done in earlier times, but nowadays this has been replaced by CT enterography. So CT enterography will be the investigation of choice whenever we want to evaluate small bowel pathologies. For example, Crohn's disease, abdominal tuberculosis. For all these, we'll do a CT enterography. Now, which is this? The fifth image that is shown, the X-ray. So the child is lying upside down. So this is what we call it an invertogram. And this was used for diagnosis of anorectal malformation. So we basically put in a coin at the anal opening and we measure the distance between the highest level of the rectal gas and the coin. And if that distance is more than 2 centimeter, then we suspect a high ARM, high anorectal malformation. But nowadays, invertogram is not done because it is traumatic for the baby to be hung upside down. So what do? We do a cross table. Sorry for that. We do a cross table lateral view. CTLV we call it, cross table lateral view. Okay. Now, which is this last image or the seventh image? So here we see that we are seeing various layers. Okay, and whenever you are seeing various layers, you have to suspect that it being a bowel. And if you're very well able to visualize layers in circles, so it is an endoscopic ultrasound. This is an endoscopic ultrasound. Okay,